Okay. Good evening, everyone, and welcome on behalf of the AHA team and our speakers. We would like to welcome you and thank you for joining us today for our today's webinar. My name is Rami Khtar, and I am the General Manager for the AHA MENA office. Today, we are presenting Get With The Guideline in Hospital program for improving patient care, to highlight the impact on patients' outcome when medical professionals follow the most up-to-date evidence-based treatment guidelines. These topics will be presented by distinguished speakers, local and international speakers. If you have any question during the presentation, please type them into the Q&A box and we will bring them, and we will also have time at the end for your questions. Allow me to introduce our moderator for today, Dr. Ahmed Sulaiman. He is a non-invasive cardiologist at Saud Al-Babtain Cardiac Center, Dammam, Saudi Arabia. He is a European certified diploma in heart failure since November 2020. In addition to National Board of Echocardiography diploma since 2018, he is a member of the Internal Regulatory Board of Research Ethics of Saud Al-Babtain Cardiac Center, and he has been involved in many research and publication in 2021. So Dr. Ahmed, the mic is yours. So you can start our webinar for today.
Sorry, maybe I'm mute.
Yeah,
you can hear me now.
Yeah,
Thank
we
you,
can
Rami.
hear you.
Good evening, everybody. Allow me first to welcome all the attendees, all our speakers today in this virtual event, when we are sharing a common goal with the American Heart Association, which is improving the quality of patient care. And without further ado, let us start with our first speaker, Dr. Ahmed Jabroun. Dr. Ahmed is a specialist cardiologist. He's a medical director and head of cardiology department in United Medical Day Care, Surgery and Polyclinic Dubai in United Arab Emirates. He was graduated from Medical University in Tripoli, Libya, certified diploma in healthcare management. His membership of Royal College of Physicians in UK and Scotland, fellow of the American Heart Association since 2003. He's a faculty of cardiology department at Dubai Medical College, and for sure he published many research articles in a peer-reviewed journal. Dr. Ahmed, the mic is for you.
Thank you very much, Dr. Ahmed Sulaiman, for your introduction, and thanks for attendance, for spending the night with us. So I'll just start by sharing my slides with you so I can start. Share screen. Okay. And so I hope you can see now the screen.
Yes, we can see it, yes.
Okay, so we're spending 2 nights talking about American Heart Association quality improvement initiatives. Basically what we call it, Get With The Guidelines. Okay, so this initiatives, it's a long time back, it's nothing new, but it's time to start thinking about it in our region, our MENA region. I'll give a little bit of introduction about this quality improvement initiatives. My colleague, they will talk about their experience and how to use it and other needed paper for that. So basically, this initiative is based on 5 common and high volume, high risk diseases, as we know, stroke, resuscitation, heart failure, atrial fibrillation, and coronary artery disease. So, an introduction, we know the NCDs or non-communicable diseases are the main cause of mortality worldwide. Even with the corona pandemic, still NCDs are the first and the commonest cause of death worldwide. It is more than any other diseases, and it accounts for about 71% of all deaths global, and killing about 41 million people annually. So it's a huge number and a big number. The cardiovascular diseases account for most of NCDs, and that's account about 17.9 million annual, 9 million for cancer, and 3.9 for respiratory diseases, 1.6 million for diabetes. So again, as I said, cardiovascular disease as a part of NCDs is the major cause of death worldwide. Those are facts published already by WHO's 2018. HA, they started to align with international mission of the WHO, what we call it 20 by 2025. In other words, the campaign targets to reduce 25% of the premature death due to non-communicable disease by the year 2025. The quality improvement program aligns with the effort to increasing application of the guideline-based care. And this leads to two things: increased delivery of acute care therapy for time-sensitive diagnosis. And number two, lead to compliance with secondary prevention therapy at time of discharge. So what we're trying to say that the 5 program which was promoted by HA for improvement are 5 sensitive diagnoses, and the time of the treatment during the acute care can make a major impact. Also, the secondary prevention therapy given to the patient before discharge can make a major impact in the patient long-term life. What is the history about the quality improvement program from the beginning? Actually, as I said in the beginning, it started 20 years back. Started in the States first as a quality improvement program for cardiovascular and stroke. It focuses on the translation of the guideline into practice in hospital setting. But the question, why? Why do we need this kind of initiative? The answer, we have a lot of guidelines published by so many societies for these 5 common diseases, whether resuscitation, when we are teaching life support courses, whether management of acute coronary syndrome, coronary disease, atrial fibrillation, heart failure, and stroke. The guideline is there, and it's being through a lot of research, peer-reviewed publications, and data. But are we applying those guidelines in our daily life in treating our patient? The answer, no. Still, there's a big gap, and this is where the quality improvement get with the guidelines comes in. It's try to reduce that gap, bring the practice closer to the guideline. So instead, over 600 peer-reviewed publications from the QI program effort increased the awareness of program and their outcome by healthcare professions from around the globe. So the international quality improvement program is based on 6 things. First of all, in state, they start building the program experience. Then they start collaborating together, getting the data, collecting it, then looking for where is the defect, where is the unmet needs, fulfilling that, and then start building the capacity to build and to work on those unmet needs, and then work on the culture and the area where the patient gets his care and her care in hospitals to create that one and try to maintain it as a sustainable program for long term. One of the studies in our areas showed that we are not different from anywhere in the world. In MENA region, there is some studies or registries done to look for our practice in the MENA region and how good we are in treating our patient. So this is one published study registry done long time back in 2008. It's called Golf Race. We were part of it here in Dubai. It was done in MENA region. It has a major conclusion out of it. After that follow-up of the patient, it recruited big number of acute coronary syndrome patients, and it showed STEMI and left bundle branch MI, only 65% received reperfusion. So a big area of people who are presenting with STEMI are not getting reperfusion. Not only that, the type of perfusion that time was mainly thrombolytic therapy rather than intervention. So 7 to 93%. The door to needle, the average for all the MENA area was 45 minutes. Okay, and that means only 37% of our patients are really receiving their thrombolysis within 30 minutes of the door. During the first day of hospitalization, are our patients receiving the guideline therapy, including aspirin, clopidogrel, beta blockers, AC inhibitor ARBs, statins? Obviously, from the number you can see in the slide, not 100%, and some of them not even around 50%. So many patients are being deprived from getting the guideline therapy in their hospitalization. And not only that, the registry showed 21% of all the patients had angiography done for them in the hospital admission. And the mortality was around 3%. So in conclusion, it's a big area of improvement in using the medication, reducing the needed to door, and utilizing the cardiac catheterization services in our region. What happens in 2017 is that the QI from HA started to reach us here in the state, in the MENA region. So the first launch, Get With The Guideline, was in UAE and Saudi Arabia Kingdom, which are first country outside UAE state to implement this cardiovascular program and hospital care improvements. So far, up to date, we have some people or some sites already recruited and are using the Get With The Guideline software with the help of American Heart Association, about 13 sites. Some of the sites are pending for approval, about 8 sites, but major number of the people are still having prospects and thinking about it and interested about Get With The Guideline programs, where some people very slow are getting to build their knowledge. So one of the idea of having this tonight program is to build knowledge and to move more toward active site working on this program. So what we mean by quality improvement program, the 5 of them, the stroke, resuscitation, heart failure, AFib management, and coronary artery disease. What we mean by those programs? So there are core principle of those program is to translate guideline, as I said, into clinical practice in a hospital setting, day-to-day practice of those diseases in a hospital setting. Try to capitalize a teachable moment for both patient and their families. On the same time, try to get changes based on data. What we do every day, based on that, we make decisions. And then if we do that, we celebrate our success of improvement, compliance, and we can best practice sharing with the network of hospitals. Does it work? Is there any benefit of that? The answer is yes. The impact of over 10-year experience of Get With The Guideline has shown it lowered the cost through decrease in the hospital length of stay, decreases 30-day readmission, and intervention focus on evidence-based secondary prevention, eliminate inequity in care between men, women, older patients, and younger patients. And there's more than 600 published scientific reviews of those guidelines. I Get With The Guideline program, and those all published recently. So what is the benefit for hospitals themselves whom participated in those programs? First of all, they will identify their current baseline, how they are. You don't know whether you're doing well or not unless you check yourself, look to the mirror. So you see, are you following the key indicators that you put for yourself? Are you compliant with them? Then you benchmark with the others who do the best practice and you see how is that. Then you look for where is the area of improvement. So identify your opportunity of improvement. Then HA staff will help you to identify strategy for improvement in delivering the guideline-based therapy. And then you have the access to clinical tools and resources provided by HA, and you can get the public recognition of the achievement all over the world. How we can participate, who can participate? So hospitals of any size, as long as they are caring for patients with heart disease or stroke, can be part of this program. Currently, the program is offered in UAE and in KSA with an effort and plan to have it covering all the MENA region. There is no restriction on the patient volume to participate in the program. In fact, this program will help those hospitals to be best practice hospital and will encourage to increase the volume and the guideline-based compliance. How we do that, the journey of success, starting by signing the agreement with HA team in our office here. Then the HA will start working with you hands in hand. It's not just an agreement and the end of the story. The HA will start helping the team of the hospital to build up their multidisciplinary team who will identify the data and start abstracting it and feeding it in the system. Once they enter the first baseline 30 medical records, they know their practice. They review their data in real time to know what's their current compliance to guideline and how far and how many steps they have to walk to get there. And then they're working with you in developing strategy for improvements. Once you achieve recognition status through the meeting, your key performance metrics, we celebrate together the success. How we do that? It is all based on patient management tool, where my colleague, Mr. Rubashi, will talk about how to use it. It's powered by IQVI. It's a patient management tool, BMT we call it. It's a web-based tool for entering the data. It's to provide on-the-moment current case management capability, real-time data access. It includes error, warning checkups, and mistakes that you could do and you can prevent. It's linked you to coding instruction and measure your logic and reasonable documents, all integrated in one tool. This is how the tool looks like. Rubashi will explain more detail about it. And after that, you will get your recognition from HA. You can show the seal. The difference around level reflects amount time of how long the hospital demonstrate compliance and performance with the guidelines. So you could get a bronze after starting the program for 90 days. You can upgrade to silver if you continue for another 1 year, which is 12 months. And you can get to the level of gold if you do it for 24 consecutive months or more. So those are different levels of award you can get. So get with the guideline, give you the opportunity to perform real-time benchmarking, improve your efficacies, engagement of multiple departments in the effort. So everyone feels he's part of the hospital quality program. Also give you recognition by HASA of their performance and commitment to improve care. Thank you very much.
Thank you, Dr. Ahmed, for this concise review of the concept of get with the guideline. If we want to put it in one sentence, it's really, as you mentioned, it's the translation of guideline into practice. This could be sounds simple, but rather than it includes a lot of details. And this will take us to our next speaker, Ms. Ruba Ibrahim. Ms. Ruba, she's Associate Program Manager, American Heart Association in Middle East and North Africa in Dubai, United Arab Emirates. She got the master's degree of nursing from Hashemite University in Jordan, 2013. She's qualified in diploma degree in quality management in 2013. She has around 10 years experience as a clinical instructor in the American Heart Association in all disciplines. And she's leading the Get With The Guidelines Quality Improvement Program in MENA region. She's going to talk to us about the Get With The Guidelines registry tool. We will go a little bit in more details after the general overview from Dr. Ahmed. Okay, Ruba, go ahead.
Thank you, Dr. Ahmed. Good evening. Assalamu alaikum, everyone. It's a pleasure to be with you. In continuation for Dr. Ahmed Gabroun presentation, I will take you to the small journey to our patient management tool. We will do a live demo, but before that, let's just have a quick overview about patient management tool. As Dr. Ahmed mentioned, that our patient management tool is an online interactive assessment and reporting system. which will give the hospital the capabilities to enter their data to benchmark it regionally, nationally, and even internationally based on the programs that they are using. We have 5 modules, and based on the program that you choose, you can benchmark from all the hospitals that are using the same program. Besides that, it gives the hospital a good database for research and publication, besides the robust clinical tool library for each single module. From the other hand, it is a real-time patient-level reporting to eliminate delays in performance feedback. Once the site abstractor, once the staff entering the data, they will receive an immediate feedback about the error of entering the data. And at the end, before the submission even, they can recognize the area of the error and they can fix it before submission in. After that, we will have, or let's say parallel to this one, as an AHA, we are providing continuous support to the sites by having weekly meetings to give them an immediate feedback about their performance against the clinical guideline. Besides that, they will be able to download the data, either raw data or even in many formats for their evaluation, to be shared with the management and to look for area of improvement. I will not take that much time to talk about it. Let's go together to have a live demo to know what is actually the patient management tool to make it easy for everyone. Let me share my screen again. I'm sorry for that. Okay. Sorry. Okay. So here, I'm just wanted to be sure that you can see my screen. Yes. So this is the participation login page. Before that, we just want to say that American Heart Association doing continuous training for every single participating hospital for the site abstractor. After they got the training, each abstractor will receive the login credential, the username and the password based on the program that they choose. Here in the participating login page, you will find the username and the password, which everyone will receive it in his own email, each site abstractor, where you receive temporary password. After you log in, you need to change your password. Beside that, you will find a link for the helping login. In case you found any challenge in doing the login, you can just note the information from this slide. And here are just an information how to contact the help desk by the email. For the telephone number, it's internationally, but we have another telephone number that you just see it in the community page and the home page to contact for help. So now let's do the enter and to see what does the community page look like. But before that, let's say that this is a demo account for the training purposes. It's not the actual demo. So here is the community page, which is the home page. And you can see in the bottom, there is then a full name of the staff or the site abstractor beside the hospital name. And you can see in the community page, there is a lot of, let's say, mini and variable of sections. For the first one, get started, here you can find the let's say the programs that the hospital rolled in. Here we have a stroke, resus, heart failure, atrial fibrillation. In line of this one, there is 4, let's say, tools. There is 4 legends. For the first one, you can see the single-headed one. It's the new enter a new patient. Once you click this one, it will take you to the page where you will start entering your patient data. While for the double-headed your patient grid, it will show you all the patients that you have entered for the program. For the paragraph, where you can run the reports, and the last one is the resources. In the resources, you can find a useful and a valuable of the library of the information, just like the coding instruction manual will give just a detailed about, let's say, how to enter. I'm sorry. Yes, this is the coding instruction manual, which define each measure, and all of these header are hyperlinked. As an example, if you just press in the Admin Joint Commission, it will take you immediately to this part to know exactly how you need to enter this one. Beside this one, there is just, let's say, the frequently asked question, which is a PDF printable format that have a valuable resources of the question format for our module. Then we have the My Hospital, where explain or detail your participating hospital. Here the module, here the number of the records have been entered, and here the baseline data starting date. While for the support contact, here the phone number for the United Arab Emirates, for the Saudi Arabia, since the programs are launched now only in Saudi Arabia, United Arab Emirates. And here's the email where you need to, if you have any information or you need any question, you can just send for them an email. For the snapshot here on the left side, it's all the, let's say, the participating hospitals, let's say the programs, the number of the hospitals for every single program that participating, and here the total number of the reports. In the My Reports, you will find a hyperlink for predefined measures. Once you extract any report, you can save it, and you can just click in the predefined report to go to the saved report. And here are some of the useful information with the useful links, such as the WHO and the Joint Commission. Now we'll do just a quick tour for one of the patient entry, and let's see what is exactly this registry tool. First of all, we keep recommending and advising our participating hospital in regard to the patient ID that we are recommending them not to put any information that make the patient easily identified, just like the patient name or even patient date of birth. They can just enter the hospital name, participating hospital name, initials, besides serial number that they are agreed on as per their hospital, and the maximum characters are around 20. Here, just a quick to show you what exactly it's include like, and this is for a demo for the heart failure. Here for the demographic data, including the gender, the race, ethnicity, while for the admission, for the date and the time, for the medical history, for the admitting patient, for the initial diagnosis of the patient, beside the medication administration, here for the lab. It's all the information that the hospital taking from the patient during admission. For here, the clinical codes, just you need, if you are not familiar with the code, you just need to practice. You just need to enter the description, just like letter as an example. And you can see exactly what it's look like and what's the description. If you don't know what's this code, just you will find the description here to enter the suitable code for this one. For the in-hospital, here all the procedure, the treatment that have been done for the patient, you just simply need to click in. It's either yes or no, or even to click. There is not much data that you need to write, actually, it's not written. Besides that, just one of the benefits of the guideline that we have elaborated the COVID-19 vaccination and the information in the tool, where you can enter the date and the time of giving the vaccine. Here for the discharge data, it's the same with the admission. You just need to mention the lab result of the patient and all the medication that have been given to the patient, if it is indicated, contraindicated, and if contraindicated, what's the reason for contraindication of this medication. Till the end, based actually on the module that you have chosen, beside the discharge instruction. And one of the most important things, that's as an example for this module, is the follow-up date and visit and time. We just are monitoring this one. For the admin and joint commission, it's just only if this patient have been sampled in any clinical trial. Historic is for the history of the patient, and measures here will give you a description for the measures that you have entered. Either it is compliant with our recommendation or not. The last thing from my side that we'll mention is how to extract the reports. As we mentioned in the beginning, that patient management tool or get with the guideline give you the ability to benchmark your performance against the same hospital that using the same program, either regionally or internationally. In every program, there is a key performance indicator that we call it configuration measure. So you can evaluate your hospitals based on these measures. And we have a recommended score for every single configuration measure, which is around 85%. At the beginning, you need to choose the interval. It could be monthly, it could be quarterly, annually. Let's choose an example monthly, and you can choose the year and the month you need. Let's say October, okay, 2020 as an example. Here you need to choose the measure that you want to extract the report for it. Every single measure in the PMT could be extract a report on it. So either you can choose measure by measure, or you can just extract a report for all the measures that you have entered. Here in the format, there is 5 options, starting from the bar chart, ending by the patient records. But some of these measures could be reported in 2 formats, not in the 5 formats. So let's choose the bar chart, and here where you can do the benchmark. Either you will do it regionally with the same area, or it could be internationally. For generating report, the report that you can extract it could be printed, it could be exported to the Excel sheet, or even exported to the CSV. And here you can see exactly how is the performance in every single month, either by graph and even by number. As I said, that this is account for demo, so we have just entered the data to show it for you for the purpose of the training. Here for the evidence-based beta blocker, one of the measures, here the success measure. The denominator is the cases that are compliant with our recommendation, with our measures, or the denominator that are not, let's say, not complying with our recommendation. Here for the third measure, and here for the post-discharge, which is the fourth measure for the American Heart Association to the guideline heart failure program. So that's just a brief summary about our patient management tool. For more information, you can contact us. Thank you.
Thank you for this informative review for the patient management tool. Frankly, we are working with this patient management tool for our heart failure program in Saud Al-Babtain Cardiac Center for more than a year now. And we have to say it's very friendly, it's easy to be used. It provides a lot of options. When you are presenting it within like 15 minutes, it maybe looks like it's including a lot of details, but frankly, with daily use, it's very, very friendly. Now,
thank you, Dr. Ahmed, for this feedback. Thank you so much. Thank you.
This is the reality. Now we can move to a real successful project that already took place in Saud Al-Babtain Cardiac Center with one of the aspects of patient improvement projects with the American Heart Association, which is the resuscitation. And the leader in this field, Dr. Hisham Abdullah, he's my brother, my senior in Saud Al-Babtain Cardiac Center. He's associate consultant, cardiologist. He's member of scientific and organizing committee in Saud Al-Babtain Cardiac Congress here in Dammam, Saudi Arabia. He got his medical doctor degree from Panha University in Egypt in 2011. He's a medical education coordinator, and he is the chief instructor in Saud Al-Babtain Cardiac Center for many years. He also well-known speaker in more than 100 cardiology activity inside and outside Saud Al-Babtain Cardiac Center. Dr. Hisham, the mic is for you.
Thank you very much, Dr. Ahmed. I will share from my side. Is it clear now?
Yes, we can see it.
Okay. Okay. Before starting, I would like to thank all organizing committee for inviting me to chair in this eminent course. And before starting, the cardiopulmonary resuscitation actually, it started on late 50s. And as you see here, at the late 50s, they are using just a pillow method as a resuscitation technique. But recently, and as you will see here, there is independent automatic mechanical chest compressors that can achieve proper chest compression while the operator are doing his intervention in cath lab. GWTG guidelines resuscitation has its roots in American Heart Association by the National Registry of Cardiopulmonary Resuscitation. Actually, it started on 1999 to collect resuscitation data from as national-wide countries and to create evidence-based guidelines in patient CPR. Why GWTG guideline resuscitation? Actually, the GWTG guideline resuscitation facilitate many factors. Number one, it is efficient to capture and analysis reporting data in a local hospital, and it will analyze and tell us about the effective current guidelines application in the real practice. Also, it leads to a creation and dissemination of many knowledge and the development of evidence-based practice that can help us in the future to change the guidelines as regard the cardiopulmonary resuscitation. Also, it is a quality improvement program for in-hospital cardiac arrest, and it will lead to a very direct access for scientific research. Also, the aim usually is to turning guidelines to lifelines. As you know, that the brain deaths occur about 6 minutes after the cardiac arrest. If early and effective CPR done, it will keep blood flowing to the brain and vital organs, which can ensure a full recovery. If CPR given within the first 2 minutes of a cardiac arrest, the chances for survival will be doubled. And all the scientific evidence has demonstrated that survival from a cardiac arrest is dependent on 2 factors: the quality of delivered CPR and the strict adherence to the recent guidelines. Our experience in Saud al-Babtin Cardiac Center. Our mission in Saud al-Babtin Cardiac Center is to save more lives by preventing the in-hospital cardiac arrest and optimizing the outcome through quality improvement and knowledge translation and research. Our approach is excellent cardiopulmonary resuscitation and early defibrillation for the shockable rhythms, and all our members can evaluate any form of ECG interpretation that need cardiopulmonary evaluation. All this lead to emphasize the excellent CPR. Anything short in this standard will not achieve adequate cerebral and coronary perfusion, especially in our cardiac patients. Saud al-Babtin Cardiac Center have many types of resuscitation. As you will see here, we have many groups. The first one is a team of medical emergency and rapid response team. They are dealing with the unstable patient, with the critical patients. You know that most of the researchers tell us that about 80% of the cases develop cardiac arrest, they become unstable in about 80% of the cases. So dealing with this critical patient, dealing with this unstable patient, it will prevent the occurrence of cardiac arrest. We have also the acute respiratory compromise team, the respiratory therapist dealing with any event that require emergency assisted ventilation. And finally, we have the code blue team, the CPR team, dealing with any event that need high quality CPR or defibrillation when needed. Our Saud al-Babtin Cardiac Center journey through the project, we have certain measures are being monitored, aiming to improve the outcome of our hospital cardiac arrest patients. Number 1, the events to be monitored or witnessed. Number 2, the time of the first shock. Number 3, the time of the first epinephrine dose. And number 4, the confirmation of the endotracheal intubation placement. We have for the data entry also as a part of our journey in the Get With a Guideline resuscitation program, the team building. Team building, we have what's called the data abstractors. All our data abstractor teams are certified by the American Heart Association after completing the Get With a Guideline resuscitation training program for data abstractors. There is a dedication among our team members and the assignment between our team members and commitments among our team members. How did we manage our recording to be constant? We built up our multidisciplinary team for different departments from different specialty, like in CCU, in critical care, ICU, in cath lab, in chest pain unit, in OR, in OBD, in adult cardiac wards, and surgical ward. All they have the ability to monitor CPR quality and the 24 access for CPR data entry. How did we manage our recording to be a constant? Also, after we start the program, we are enhanced to provide additional resources and the tools and the benefits like excellent staff performance through benchmarking and feedback across our hospital patient getting cardiac pulmonary resuscitation, professional educational opportunities like lectures, workshops, webinars, and the data collection, continuous quality improvement, and getting easy access to the most updated research and starting RQI. Starting our QI, we get a lot of benefits actually from starting our RQI, which is the Resuscitation Quality Improvement Program. It has a better innovation and the mastery of learning among all our staff in performing CPR into cardiac arrest patients. And by building both the GET with the guideline resuscitation and the RQI in our center, or our staff now become confidently response to any form of a cardiac arrest at any time. Our quality measurement during the CPR, number one, the time, يعني percent pulseless cardiac arrest. It is monitored or witnessed or not. Number two, the time of very shock should be equal or less than 2 minutes to giving the shock for a patient with ventricular fibrillation and pulseless ventricular tachycardia. The time to intravenous epinephrine should be equal or less than 5 minutes in asystole and pulseless electrical activity, and the confirmation of airway device placement in the trachea. Let us to be practical, and you will see now how we improve ourselves in Saudi Al-Batin Cardiac Center. We here during 2020 from January to December, and here 2021 from January to December. As regards the time of the first shock, which should be equal or less than 2 minutes, we improve ourselves from 88.9 in 2020 to 96.2 in 2021. As regards the time of intravenous epinephrine, which should be or equal 5 minutes in asystole or pulseless electrical activity, our goals actually improved, as you see here, from 84.6 improved to 89.7. So there is significant improvement in this aspect. As regards the patient which should be monitored or witnessed during the cardiac arrest, in 2020 and 2021, both are 100%. So at least we keep our standard is the same. For the confirmation of endotracheal tube placement, also the same in 2020 and 2021, 100% here, 99.3, and almost the same in the successive, the last 2 years. How we are evaluating also our quality as regard cardiopulmonary resuscitation, not only per year, but also per month. Every month, we have monthly evaluation for all the parameters during CPR. And as you see here, this is month by month as against the number and the percent of the patient getting this service. How did the program help us? So the Bacterial Cardiac Center benefits from GET with the guideline resuscitation. It has significant improvement in resuscitation practice. And this is really what we are seeing in day-to-day clinical practice. Monitoring the process of guideline adherence. There is improvement in different dealing with different events related to CPR, and all our staff now can dealing with any scenario or any arrhythmia during cardiopulmonary resuscitation. Monitoring the in-hospital resuscitation, comparing our performance with other hospitals, ensuring consistent data definition and collection, measuring compliance with the latest American Heart Association resuscitation guidelines, improving staffing, training, equipment's allocation based on data, involved more data abstractors from different specialty, and direct access for scientific research. Also, orientation of our staff to the new guidelines by monthly education program, and we start it actually, and the distribution of the new guidelines to all the units 24 hours. We start also the RQI, resuscitation quality improvement, and it helped us a lot actually. Our members now can refresh vital CPR skills in just a minute. Help our members to provide high quality CPR that lead to a better patient outcome. Also, it can provide for us audiovisual coaching on critical components of high quality CPR and track and document individual student performance. This is when we are starting the RQI, and we are certified for that since about 1.5 years. Also, the GID was the guideline resuscitation help us to use the automatic mechanical chest compression devices. It provides a uniform, effective, high quality CPR. Any operator can do his job during the coronary intervention, and the Lucas or automatic mechanical chest compress devices provide continuous, uniform, effective, high quality CPR. And also it provides consistent, not interrupted chest compression, angiography, PCI, ECMO, cannulation can be made very easily during CPR without any interruption. The device is more easy, portable than a group of rescuers. We started the mechanical chest compression devices in Saudi Baptine Cardiac Center since the beginning of 2019. Also, the program helped us in making a policy for how we are dealing with a patient with COVID-19 virus infection getting CPR, requiring CPR. Any of them, either with they are a cardiac patient or not a cardiac patient, they can get a cardiac arrest at any time. So we're making a policy for that, and all the staff are familiar how they are dealing with the CPR in patient with COVID-19 virus infection. And even during this pandemic situation, we are not stopping teaching all the staff, and maintaining them. They are become confident enough, and they have competency or competent skills in saving life of that patient. Also, we have 24 hours continuous assessment care. All the teams in Saudi Baptine Cardiac Center who dealing with this critical patient, they are collaborating together. The RRT teams, the respiratory therapeutic therapist team, with the Code Blue teams, with the CCU surgical ICU teams, and all these are collaborating together to provide high quality CPR, and they are dealing with the cardiac patients very successfully. And there is also acute debriefing either by individual basis or through the team immediately after the resuscitation. Get with the guideline resuscitation help us in updating our CPR resuscitation form, and as you see here, become very simple, easy filling form matching all the new guidelines. Now we are working on applying the target temperature management protocol for the patient post-cardiac arrest or the patient getting ROSC. We are working on it, and it will be elaborated very soon, maybe after 1 or 2 months after the CPR committee approval. Saudi Baptine Cardiac Center future perspectives. We are willing to serve as an advocate to other hospitals in Saudi Arabia as regard the Get with the Guideline Resuscitation project, aiming to be a leader center in the Eastern Province area and getting Get with the Guideline Resuscitation in heart failure awards. We got already the Bronze Award, and we are aiming soon to get the Silver Award. Thank you very much.
Thanks, Dr. Hisham, for sharing with us the details of this journey of success in Saudi Baptine Cardiac Center for the resuscitation with the support of Get with the Guidelines. When we are talking about resuscitation, we all know seconds and resuscitation according to the guidelines is going to change the outcome of the patient dramatically, while the opposite is linked clearly with worst outcome. And getting this improvement, quality improvement, continuous observation of practice is the key of continuous success. Now I think we will have our expert from US, Lois Morgan. Lois, she's the Director of International Quality Improvement Programs in the American Heart Association. She has the Bachelor of Science in Nursing from St. Anselm College in Manchester. She has Master of Science in Nursing Education from Villanova University of St. David. She is certified professional in healthcare quality since 2009, and she has experience for more than 30 years as a nurse in various healthcare settings. And despite she's looking younger, but this is what we know. She also member of the American Heart Association Quality of Care and Outcomes Council and the Cardiovascular Nursing Council. She's going to talk to us about research and publications and get with the guidelines. The mic for you, Susan. Go ahead.
Thank you so much, Dr. Solomon. And it's a pleasure to be here this evening with all of you. It's been really great to listen to the presentations today that really represent some of our history of Get With the Guidelines, as well as the experience, the real world experience as described by Dr. Hisham. What I'd like to do is to take us a little bit in a different direction, which is really to think about when you contribute and participate in quality improvement initiatives, what does that mean even within your hospital as well as outside of your hospital regarding research and publications, because you are gathering data and getting insights, and these can be really valuable to share with others. Ruby, you can go to the next slide. So let me just start by sort of giving you Get With the Guidelines by the numbers. Get With the Guidelines was launched in 2001. It now has over 21 years of active program and registry experience. As mentioned previously, there are 5 clinical modules, and we do have a COVID module. Ruba shared with you a little screenshot of some COVID data points, but we also do have just a standalone COVID registry that we launched back in the April of 2020, very quickly after the pandemic made its appearance, and obviously has continued to be present in our lives. So just wanted to share that we are actually, besides Get With the Guidelines, actually gathering meaningful insights specific to COVID. In the US, we have more than 2,000 US hospitals implementing one or more of our Get With the Guidelines modules. In the US, just to give you a frame of reference, we have about 4,400 hospitals, acute care hospitals. And so we have nearly 1/2 of those hospitals that are participating in one or more of our programs. And those patients that are served by those hospitals, it actually represents more than 80% of our US population that are actually within a very close distance to one of our Get With the Guidelines hospitals. Over the course of the 20 years, we have more than 11 million patient encounters entered, and we have more than 650 publications that are in peer-reviewed journals. I'm not even giving you the statistics around abstracts and posters that have been presented at many professional conferences, both US and international. So what have we learned over these many years? Let me just give you, I'm going to highlight for you some of the findings from some of these research publications. And let me just start by letting you know that if you go to the AmericanHeart.org website and click through to the Focus on Quality area of the website, we have links to all of our publications for all these many years. So there's some great reading there for anybody that would like to take the time to do that. But let me start with this article, which is about our Get With the Guidelines heart failure module. This one is interesting because I think we all might have a general thinking that hospitals treating high volume of heart failure patients have better outcomes. But this is not necessarily the case, as was noted in this article. After risk adjusting this study noted that there was minimal association with mortality and readmission up to 6 months post-discharge related to heart failure volume. So what this really is telling us is that the recommendation is that participation in a quality improvement program that is intended to drive adherence to guideline-directed medical therapy is that which can really bring an impact to patient outcomes. You can go to the next one, Ruba. Now, this article looked at cardiovascular risk scores in predicting inpatient mortality. And it was interesting in that it was a heterogeneous cohort of patients that were in a intensive care unit, meaning these were not necessarily all heart failure patients. So there were multiple risk scores that were applied. We have one within Get With the Guidelines heart failure that's actually built into our program. There are also some risk scores associated with the Optimize HF program. That's called the EFFECT score. And then ADHERE, there's another score called ADHERE. Now, what the sort of the bottom line here is that the use of cardiovascular risk scores can be helpful in understanding individual patient risk, which in turn may impact clinical decision-making. So it even goes beyond just the heart failure patient. Really, all patients can benefit when we as clinicians apply a validated cardiovascular risk score. We can move on, Ruba. Now, this study, which looked at the trends in non-cardiovascular comorbidities among hospitals, this showed that a heart failure patient was looking at heart failure patients with multiple comorbidities. And the comorbidities mentioned here, though, are non-cardiac. So they were COPD, anemia, diabetes, obesity, and renal impairment. This result was that there are more and more patients being admitted for heart failure that have multiple comorbidities, which in turn are associated often with worse outcomes. And so the key message here is that there's a need to not just be focused only on the heart failure, but to consider the other comorbidities and ensure that you have appropriate consultants and or yourself managing to those comorbidities to ensure, hopefully, of course, to drive to an improved outcome. We can go to the next one, Ruba. This one was a little bit interesting in that it looked at early ambulation of the heart failure patients. I think we all struggle sometimes with how quickly do we get people up and about, how aggressive are we with their activity. And this study looked at early ambulation in the heart failure patients to see if it made a difference in their length of stay, their 30-day readmission, and mortality. And it was noted that those hospitals that were in, if you would, the top 25th percentile for use of early ambulation, their patients showed a 30% lower readmission rate. Now, some of the patient characteristics that lend itself towards early ambulation, as you consider that for your patient, would be things that are probably somewhat common sense, right? So younger age, in this case, it was noting males had a better, was more of a characteristic of that early ambulation success. And for this was a study based in the US. And interestingly, there was an impact if you were in a northeast region of the hospital, and it wasn't necessarily a good impact. So I live in the northeast region of the US. So that makes me stop and think about early ambulation in the patients that are treated around me. The next study. This one is looking at, I mentioned the COVID-19. So now this one was looking at our stroke, Get With the Guidelines stroke, and the impact during COVID-19. And here it demonstrated that Get With the Guidelines stroke hospitals pre-pandemic, and that their performance with the acute timely treatments, and then looked at the after the pandemic was initiated, which was February 4th of 2020 is the timeline. And what this showed is that the stroke presentations did decrease on average about 15% per week during the COVID time period. But the good news is that those that did present for presumed stroke did not experience any delay in treatment. And as we know, for heart attacks, time is muscle, and for stroke, time is brain. So that was the good news in looking at this study. And if you'll go to the next slide, Ruba. Now, this one looked at the association between thrombolytic door-to-needle time and 1-year mortality and readmission rates in patients with acute ischemic stroke. And perhaps no surprise is that the bottom line message is that particularly for patients in the older age group, those with acute ischemic stroke that were treated with TPA in the shorter door-to-needle time frame, it was associated with a reduction in all-cause mortality and reduction in readmissions in that post-discharge time frame. I will just comment that, Get With the Guidelines stroke has been utilized since 2003. So we have an 18-year history. And when we started with Get With the Guidelines stroke, at that point in time, the hospitals were administering TPA about 30, not even 30% of the time. I think it was 27.8% of the time. Now we are 18 years out, and now the percent of timely administration of TPA is literally up at about 90% plus for our Get With the Guidelines stroke hospitals. So this consistent application of programs that drive guideline-directed medical therapies really can have a long-standing impact on your hospital's performance. I think that's important for all of us to think about. We can go to the next one, Ruba, please. This study is looking at the use of epinephrine before defibrillation in the cardiac arrest patient. And Dr. Hisham actually did mention this as the use of epinephrine, I think, is one of their focused areas. What I found interesting in this is, though the guideline is to prioritize immediate defibrillation for the in-hospital cardiac arrest due to the shockable rhythm, in this study, it noted that 1 in 4 patients are treated with epinephrine before the defibrillation, which is actually counter to the guidelines. So once again, it just helps us to understand, and this is what Dr. Gabroun mentioned early on, there are guidelines that help us to understand what is what would be the optimal therapy to administer to our patients. It then becomes our responsibility to certainly be informed and knowledgeable about the guidelines, but equally important is to make sure that we are putting those guidelines into practice in a regular way. And sometimes I think, just from my experience, of many decades in hospital care, sometimes we do things because that's how we've always done them. But I think programs like Get With the Guidelines really help your hospital to understand where there is opportunity to improve and to be better aligned with the guidelines. And that can be just really important to the overall intention of what we all are doing in healthcare. So I just share that as sort of my personal message, I guess. So we can go to the next slide, Ruba. So when it comes to research, what are some of the opportunities for you? So our Get With the Guidelines program really does provide hospitals across our country and now internationally that want to ensure their doctors and nurses and other staff are following the best practice guidelines, to treat their patients. So that's the overall message that we convey. But we also know that these research opportunities help us to bring new insights, even help us to identify best practices that could be very beneficial to others. You can go to the next slide. So we have research, again, with a nearly 20-year history, 11 million patients. Certainly there's been lots of opportunities. So We have research activity that's taken place at the hospital and health system level. We have, within the American Heart Association, we have early career research opportunities, and that even includes our Get With the Guidelines data for some of that work. We have national Get With the Guidelines research. We have our COVID registry. We have some newer programs, which are collaboratives for research. And more broadly, we have what we call the precision medicine platform, where actually databases can be shared and are made available to others to use. You can go to the next slide. So here's just a quick roadmap of if you were interested in participating in our Get With the Guidelines research, here's sort of the path you would travel. You would develop a proposal that would have to be evaluated with a statistical analysis plan to determine is the information, the data that you need to support the evaluation of your proposal available within our database. Then it would lead to the data analytic report that would be presented, a manuscript that would be developed, and then ultimately a submission and hopefully approval in a peer-reviewed publication. This process is specific to AFib, CAD, heart failure, and stroke. And we have a slightly modified one if you go to the next slide for our resuscitation activity. It's quite similar, but the proposal goes directly to data analytics, and then you can move into your manuscript development and peer reviewed. For all of this, if you're interested, there is a process and a submission process. There's forms to be filled out, and our staff team will be happy and delighted to direct you to that, those forms. Ruby, you can go to the next one. And I think there's a hand raised, but we'll see in a minute. This was also shown before, but it just now we've sort of, well, I should say this arrow was shown before, but now I've overlaid, if you would, the research activity, which would be generating that hypothesis, understanding the methods for the data, summarizing the results, drawing the conclusions, and presenting your findings. And you can go to the next slide, Ruba. And so this is just a quick summary of what I've basically described, is that we have a hospital level research, which is something that as we grow the cohort in the Middle East of hospitals participating in Get With the Guidelines, this opportunity for, comparative research from our Middle East cohort to our domestic cohort, et cetera, will become something really meaningful, I think. And so something that we can all get kind of excited about and look forward to. I don't know if you noticed when Ruba showed the PMT, I wanted to just highlight that in the Get With the Guidelines heart failure database specific to the Middle East, so KSA and UAE, there currently are 876 patients represented. So we're almost at 1,000 patients, which will start to give us some meaningful volume of patients to start evaluating. For resuscitation, we're at about 504 patients. It's about 600 different sort of events, whether they are medical emergency response, CPR direct, or whatever. But this is also a growing cohort of patients that will allow us the opportunity to really develop our research opportunities going forward. And Ruba, is there one more slide? I feel like there, nope, that's it. So with that, I will stop, and I will look to my colleagues to just identify if the hand that was raised is specific to my presentation or a different one. Okay, I can't see a hand raised, but I did see one before. Perhaps it's gone away. I just want to make sure I'm being respectful of the question that might have been asked. So I guess I'm turning it back over to Dr. Solomon.
Yes, Luis, thank you. Dr. Ahmed?
Yeah. Thank you, Luis. I am facing some issues with my internet. I hope you can hear me now.
Yes, we can, Dr. Ahmed, yeah.
Hello?
Yes, Dr. Ahmed, we can hear you.
We can hear you, Ahmed. We can hear you. Yes.
I have an issue with the internet. Thank you.
I can hear you, Ahmed. Go ahead.
Perfect. Thank you, Luis, really, for your input for our webinar today. We have, I think we have time for taking few questions and comments from the audience of any. Rami, you may help me if we have any questions that we can address. And in case we will wait for any questions, let me start with Dr. Ahmed. Dr. Ahmed, you give us a view for the get with the guidelines, and as you mentioned, currently, according to my knowledge, only in Saudi Arabia and United Arab Emirates are the only countries that are sharing this experience with American Heart Association outside the US. What's your comment on that, and what privilege we can gain in this, leading to countries to be like a model for other countries in the region?
Yeah, thank you, Ahmed, for your question. Actually, interesting. Yeah, so basically, as we know, it's like a human nature. When something new happens, okay, people, they'll start to resist something new, not the usual things. Time consuming, extra effort we have to do, why we have to do it, we are fine, we are okay. So this is the natural thing. When you present something new for the people, they will start to resist it. The good ones, they would try it. They would say, let's test it and see how it goes. And when they try it, they feel the difference. They feel the benefit of that. And then when the other they see those who took it, how they progressed and how they became the champions, then everybody will start to follow. And this exactly happens with everything, whether I talk about new medication, new procedure, new protocol, and new guidelines implementation. So I would say that it started in state with HA there. It's been like more than 20 years now since started. Now, for the last 4 years, it's outside state, and fortunately started now in the MENA region as the first area in the world to start implementing it. And in the MENA region, not all of it, only in Saudi and in UAE. And I'm telling you, wait for the next few years and you will see so many people going to follow it, because it's really going to help. We know there's a gap, and implementing it can help. I hope I answered the question, Mr. Ahmed.
Thank you.
Dr. Ahmed.
Yeah, I agree with you 100%, Dr. Ahmed. Yeah, addressing the gap, we all have a gaps in our practice, and addressing the gap is the first step in improvement. I agree with you 100%. Ruba, I may just try to discuss with you. I noticed in the patient management tool that there's an options for report that can give data locally inside the hospital itself, and maybe on the level of the country, and also the regional level, and also internationally. So like we have a different level of benchmark. What's your comment on that?
Thank you, Dr. Ahmed. This is one of the great benefits of using the patient management tool, is to be able to do the benchmark for the same measure and the same data that you have entered with the other hospitals that using the same program, either in the same region, in the same country, or even internationally. From this one, we can learn from each other how our performance and how other hospitals are performing, and we can share the experience. But the most important thing, which others may ask about it, is this data identified or de-identified, because we do care about the confidentiality. So it's only the numbers. It's not the name of the hospital. It's not the name even of the patients. It's just represented by the numbers. Thank you. If you have any comment on this one, Louise, please go ahead.
No, that's quite correct. That, and that was one of the reasons we felt this program would be important to bring to others outside the US, because we have very rich benchmarking in the US, but we really do want to understand, what is performance globally. And, we're an organization that has a commitment to global cardiovascular health as well. So we see this program as really an opportunity to help understand that at a global level, but even more regionally, to be able to allow you to, just understand how is your performance against others because everybody's being held accountable to the same measures. You may participate in a variety of different registries from different clinical areas, different clinical organizations, but a lot of times you can't compare them because they're not, as we would say, apples to apples. You can get with the guidelines, everybody's being compared to the same measures and the data points. So it does become a very nice kind of what I'll call a clean comparison in that way.
Thank you, Ruba. Thank you, Louis. Dr. Hisham, if you are with us, I just want to ask you, when the project of Get With The Guidelines resuscitation started in Saudi Al-Babtin Cardiac Center?
You're on mute, Dr. Hisham.
Muted,
Yes,
Dr. Hisham, you are muted. Unmute yourself, please.
You can hear me now?
Yes, go ahead, please.
Yes.
Thank you, Dr. Ahmed. Actually, when we start, actually, before 2018, we don't have any experience. We don't have any idea about the Get With The Guidelines resuscitation. I went to Dubai at that time, and I met Lewis there. And we start to know what is the idea, how we can implement the project in our Saudi Al-Babtin Cardiac Center. We start to read, but actually, Ahmed, we did not start immediately. We started after the COVID area, because enter to Saudi Al-Babtin Cardiac Center, went outside the center. At that time, we collect a lot of cardiac patients. At that time, we can collect data. At that time, we built up our experience. So actually, about 1 year and 4 or 5 months. But we did not start immediately. We did start after we collect our patients again after the COVID-19 pandemic time.
It's worth to be mentioned that our center could survive during the COVID era and continue to provide the tertiary cardiac care during the pandemic at its massive impact. And do you think, Dr. Hisham, now as we are moving to the clustering health services, our center and your experience can help in improving the resuscitation among other hospitals in the Eastern Province? Is there any projects now on the shelf to implement outside your center?
Up till now, Ahmed, we did not connect with any other centers outside Saudi Arabia or even inside Saudi Arabia, because we are, Ahmed, we are the only center in the Eastern Province area getting this program. I don't know if there is any other centers in Riyadh or not. Maybe if we find any other center outside our area, we can connect with them and we can deal with them. But for my knowledge, we are the only cardiac center in the Eastern Province area running the Get With The Guideline resuscitation. I don't know, Ruba, if you know that there is any other center around us in Riyadh or in Jeddah or Ruba?
We have 2 more sites in Saudi Arabia and 1 in UAE. Yes, correct one. Yeah, we have 2 more. We can share the names with you, Doctor, for the benchmark.
Maybe we need to work more on this project to disseminate this experience. And as Dr. Hisham said, it's something started a long time, but started to reach perfection just recent. So we need to really to share it with other centers. And
this is one of the purposes, Dr. Ahmed, from this webinar.
With you. Regarding the rest, then I will go to
Uh-oh, did we lose
Hello?
Dr. Solomon? Oh, there you are, sir. I think we thought we lost you for a minute.
Hello? Yeah, you can hear me?
Yes,
Yes.
Hello?
we can
Yes.
hear
Yes.
you.
So, Louis, if you allow me, then I will give it to Rami. Yes,
Yes.
perfect. Louis, are you supporting the research project that it's driven by the healthcare providers locally only, or you are also thinking of creating a research project that you can offer to the centers that cooperate with you and get with the guidelines project?
So is that for me? I think. Yeah. So for those
Yeah.
hospitals that participate in Get With the Guidelines, they absolutely have the opportunity to explore research opportunities. They can certainly look at their own data, and then they can propose research, hypothesis that would that they'd like to explore with doing more comparative, research. But for those that are non-Get With the Guidelines hospitals, there is a process by which a physician or healthcare provider could consider a research proposal. There is a very rigorous process for all research proposals review and evaluation. But, we really, I think that for how we're starting in this Middle East region, we really look forward to getting some regional research activity going. And I know in Saudi Arabia that we're actually having conversations with the National Heart Center to see how we might actually, bring forward a strong research opportunity for the kingdom. So we're open, and it's just more of a process more than anything, Dr. Solomon.
Great, thank you, Louis. I'm really looking for such a research project that American Heart Association can share it with the centers, for example, that working with it on heart failure or resuscitation, so that you can get data from hospitals outside the US, and also it will provide and fill a gap in the knowledge in the MENA region. I will give the mic to Rami.
Thank you, Dr. Ahmed. Thank you. So it seems there is no more questions. Before we end, we have a quick evaluation for our attendees so they can share their thoughts with us for improving future webinars. Khalid, will you please take us through the evaluation? Please, it's just a short evaluation. It will not take time from your side, from your time, just quickly. Khalid.
Thank you very much, Rami. So good evening, everyone. Thank you for staying with us until this time. So this is our evaluation. We have a group of questions. Each group contains 3 questions. So the first one about webinar management. So kindly answer the 3 questions and submit your answer so we can move to the other two groups of questions. Thank you very much.
We can move Khalid to the next one. Thank you for submitting your answers. Yes, please continue doing it. So we'll have the majority of you answers the questions. Okay. Next, Khalid, please. It's about our speakers. Okay, Khalid, done. Any other questions?
No, thank you very much. Appreciate it. Thanks.
Thank you, Khalid. Thank you. So before we end, we would like to thank you all for being here today with us and taking the time to listen to what our speaker have presented to you. And thank you, Dr. Ahmed, for moderating this webinar. Dr. Gabroon, Ruba, Dr. Hisham, and Luis, we appreciate your efforts. And if you have any question at any time or you need more information about the Get With The Guideline, don't hesitate to approach Ruba as a lead for the Get With The Guideline or anyone from the AHA team, and we will assist you. Please stay tuned, and we are looking forward to meeting you in our future webinars about stroke, RQI, and chest pain center certification, which will be shared with you on our social media and directly from the Middle East inbox. And I would recommend you to follow as well our social media and on LinkedIn, as well on Instagram and Facebook, so you can as well have the latest update and the latest information from our side. So that's all from my side. Our speakers, Dr. Ahmed, Luis, Dr. Hisham. So if you have anything to add, please feel free.
Thank you very much, Rami, for you and attendees, our speakers today. Hopefully we will meet again and again and share more knowledge and information with our colleagues at the MENA area.
Thank you, Dr. Ahmed. Thank you, everyone.
Thank you all. Bye.
Thank you very much. Great.
Still recording, Khalid, صح?